CheckMate 274 randomized phase 3 study of adjuvant nivolumab versus placebo in patients with muscle-invasive urothelial cancer at high risk for recurrence after radical resection. The co-primary endpoints were disease-free survival in the all-comer population and in patients with tumors with high levels of PD-L1 expression. We've seen that those primary endpoints reported several times now, both in the initial report and then with extended follow-up. Overall survival is a secondary endpoint of this study, and we actually haven't seen any overall survival data from this study until EAU this past year. Overall survival has been analyzed at interim analyses, but the pre-specified threshold for statistical significance had not been met. And so overall survival follow-up is ongoing, and so the results had not been presented previously. It was felt to be important to present the results because of the evolving data in this space from other studies. And so what we saw at EAU is that in the intent to treat population, the all-comer population, interim overall survival favored nivolumab versus placebo with a hazard ratio of 0.76. So the median OS was 69.5 months in patients treated with nivolumab and 50.1 months in patients treated with, or in patients on placebo. And in patients with tumors with high PD-L1 expression, the median OS was not met in either arm, but the 36-month OS rate was 71.3% in patients on the nivolumab arm, and it was 56.6% in patients on placebo. The hazard ratio was 0.56. The upper limit of the confidence intervals for both of those analyses are less than 1. But again, because of the alpha allocation and the interim analysis and the pre-specified thresholds, that did not meet statistical significance, and so the OS analysis is ongoing. I think, first of all, we have to look at the DFS data, and the DFS data from both studies is really quite similar. There's an improvement in DFS in both studies, which were primary endpoints in both studies. The other data set that's often brought up, of course, the other phase 3 study designed similarly is IMvigor10, and you can argue that IMvigor10 did not meet its primary endpoint of showing improvement in DFS, and that's true, except that if you believe the ctDNA data, then you do actually believe that there's a benefit to adjuvant immunotherapy from that study as well. It's just that patient selection did not identify the patients at highest risk. So I think there are more similarities in these studies than differences. What about the OS data? Well, I think that's where the nuance comes in. And there are some differences in a placebo-controlled trial versus an open label trial. There's some differences in the study conduct and the disposition of patients. And once you get into some of those details, that can potentially impact the OS signal. And again, the OS signal was a secondary endpoint in CheckMate 274. There's no question that we need biomarkers in this space, and we need two sets of biomarkers, and it's not clear that the same biomarkers will serve both purposes. We need biomarkers to identify who needs adjuvant treatment, because we know that a subset of patients are already cured surgically, and additional treatment cannot, by definition, benefit them. And we also need biomarkers to define who benefits from the particular therapies that are being applied, because just because a patient needs treatment does not necessarily mean that they'll benefit from the treatment that's being administered. Of course, we know that is true in all settings of cancer, including in the advanced metastatic disease setting. So we need both sets of biomarkers. Biomarkers to define who needs treatment might actually be a lower hanging fruit. These are essentially prognostic biomarkers, and in probably the most mature biomarkers to inform that decision right now relates to ctDNA being used to measure molecular residual disease. And we have data from several data sets now that this is a very promising biomarker to identify potentially patients who need treatment, but we need prospective studies to establish clinical utility to ensure that we should be using these tests for clinical decision making.